Hello, I'm Erin Cox, physiotherapist. Today we're going to talk about the anatomy and biomechanics of the hand. I'll just start sharing my screen. So anatomy and biomechanics of the hand. So first of all, the hand functionally consists of the carpometacarpal joints, or CMC, intermetacarpal joints, the IMC, metacarpophalangeal joints, MCP, and the interphalangeal joints, which would be the PIPs and DIP for proximal and distal. So if we look at the CMC and IMCs first, so this is where we're looking at the carpal metacarpal. So this is the distal row of carpal bones, and here are the bases of the metacarpals. And of course, you can also have intermetacarpal because there are also articular surfaces between the base of the metacarpal bones. You can also see that here there are areas which would be where they've got multiple articular surfaces. So the capitate, for example, will articulate with the fourth, the third, and the second base of the metacarpals. Here's an example. We've got the CMCs, which again are the carpal bones with the base of the metacarpals. We're going to also look at the MCPs, which are the metacarpal phalanges, and then the DIP and PIPs. So we're going to look at from this area here, which will be the CMCs. We're going to look now also at the MCPs, which be this area here, and then our fingers, which would be the PIP and DIP. First of all, the metacarpal and intercarpal joint surfaces. So the capitate is convex all the way around, Big Daddy, on all surfaces. The proximal side of the trapezoid and the trapezium are concave, so concave on convex. So they are concave on the scaphoid. And the proximal side on this side is all convex on concave. So you've got the lunatum or the lunate and the triquetrium on the radius and the TFCC, as well as the capitate and the hamate are convex on the lunate and the triquetrium. If you actually go even further, the fourth and fifth metacarpal bases will also be more convex, but they're variable. They might be a little bit more planar, but you can see well here that the second and third metacarpal bases are concave on convex. So these are concave on convex. The CMC ligaments, I did in a separate video. Now we'll look at the capsule. So this capsule is strong but loose, which allows increased mobility, thick radially and dorsally, and reinforced by the palmar oblique ligament and on the palmar and ulnar aspects. So that's for your first CMC. The classification of your first CMC is synovial. It's simple and it's an unmodified cellar. It has 2 degrees of freedom, flexion, extension, and abduction. The full closed pack position is full opposition or extension and abduction. The resting position is mid position, and the capsular pattern is equal loss of extension and abduction or full flexion. McGee says abduction more than extension, but equal loss of extension, abduction, or full flexion. Normal end field would be capsular, and the soft tissue approximation in adduction. The osteokinematics, impure swing about an oblique axis of 35 degrees from the coronal plane. So it's just talking about how we have the anatomical position, but we are away from that axis. So remember in the other video, I talked about flexion and extension. So for the first CMC, which would be down here, the dorsal side or the posterior surface is going to follow along the thumbnail and the palmar all the way down here. So that would be, this would be flexion and this would be extension. But to think about, there will be a conjunct rotation of flexion, because when you need to grasp, you have to rotate internally, and when you have to open your hand, you will have to rotate externally a little bit. In the resting position, the MC moves in an ulnar direction with flexion and a radial direction with extension. Opposition is combined flexion and abduction with some internal rotation. Ulnar and palmar circumduction with medial rotation, basically. And the dorsal oblique ligament, which I already talked about in another video, is under tension, and muscle forces create this tension more so than the joint surfaces. And then to reposition it from opposition, then it's combined extension and then adduction, and the radial and dorsal circumduction with external rotation of the first metacarpal as well. We will, in class, look at the different glides, how to do them. And again, flexion going to go with a palmar glide, extension with a dorsal glide. Adduction is going to be with a radial glide, and abduction with an ulnar glide. To look at the articular surfaces, the first CMC is sellar, but the second one and third we said are going to be concave on convex, and fourth and fifth are convex or maybe planar. So the second metacarpal articulates with the trapezoid and has small facets for the trapezium and the capitate as well, as you can see here. The base of the third metacarpal is more concave again. So we said the second and third are concave and articulates with the convex capitate. The fourth and fifth metacarpal bases are slightly convex or planar, and they are going to articulate with the hamate, and the fourth is a slight one with the capitate as well. The fifth articulates only with the hamate. The metacarpals articulate together except for the first and second, because the thumb is going to stay loose in order to be able to grab things. So we have the intercarpal joints as well. The CMC ligaments, the second to the fifth, so the dorsal are very strong. The dorsal carpals to the metacarpal bases, and the interosseous are two short, thick fibrous bands connecting distal, capitate, and hamate with the third and fourth metacarpal. So we have some interosseous ones, and we also have the dorsal ones that are between the carpals and the metacarpals. So the palmar ligaments are more oblique, and you can see that pillar in the middle formed by the capitate and the third metacarpal and the digit, and you can see that these ligaments sort of go up and toward the middle in an oblique fashion. The intercarpals link the adjacent metacarpal bases on the palmar aspect. The capsule is thick and loose. The metacarpal bases to the adjacent carpals encompasses the intermetacarpal joints between the adjacent bases also. So we were talking about the metacarpals with the carpals, the metacarpals with the, metacarpals with the carpals, but also the intermetacarpals, so in between. So just to note where we are, so these are the metacarpals in the palm of the hand, and we're talking about down here how they articulate with the little carpal bones, and then that there are intercarpal joints as well. So these would be complex joints because there's more than one joint in the capsule. Absent between the hamate and the fourth and fifth metacarpals. The classification is synovial. Are they all compound? As I just said, there would be the second, fourth, and fifth would be compound. Modified ovoid, and the degrees of freedom are flexion and extension and abduction, because we can do this closing and opening. The closed pack position of the second to the fifth CMCs is full extension or fanning. Resting position is slight flexion with ulnar deviation or slight folding. The capsular pattern is a loss of flexion more than extension, or folding more than fanning. We want to be able to close our hand, basically. Normal end fill would be capsular. The osteokinematics, the flexion extension, is an impure swing about a coronal axis in a sagittal plane. So the coronal axis, of course, but as we indicated before, there's a combined movement which will give us this impure swing. So there's a conjunct folding with flexion, and which means we have an internal rotation of the second metacarpal and a conjunct external rotation of the fourth and fifth metacarpal with flexion. And think about your anatomical position so that if I were in an anatomical position and your base here in the middle is the pillar, so your third metacarpal with your capitate, so the lateral side is going to do an internal rotation, just like the same way that your shoulder would go, and then the medial side or the ulnar side is going to do an external rotation, and that's with the reference of the axis of the body. Conjunct fanning with extension, and of course, then the rotations will be the opposite. Total range of motion, minimal mobility in the second and third CMC, more mobility in the fourth and fifth, again, to help us with grasping. Abduction in reference to the third metacarpal as now. So the abduction, we talk about adding it to the third or adding it to the third. And there's an impure swing because there's a little bit of rotation that happens with that. So conjunct fanning with abduction, fanning is the rotation, and then same with the folding as well, or if we go like that or like that, you can see. So there's conjunct folding with adduction and conjunct fanning with abduction. Arthrokinematics, the accessory glide. So for flexion or folding, there's a palmar glide of the second metacarpal on the trapezoid. There's a palmar glide of the third metacarpal on the capitate, because don't forget they are concave on convex. Conversely, there will be maybe a dorsal glide of the fourth and fifth on the hamate, but if they're planar, you can check both directions to see if either direction would help the movement that's missing. And extension is fanning. So extension would be the dorsal glide of the second MC on the trapezoid, dorsal glide of the third metacarpal on the capitate, again concave on convex, and the palmar glide of the fourth and fifth on the hamate. But again, don't forget, this could be planar, so you could check both directions. Accessory glides of abduction or abduction. Can this really be done other than the fifth metacarpal? Abduction described relative to the third finger. So the radial glide of the second metacarpal on the trapezoid, is that really possible? And the third is stationary. And then again, a radial glide of the fourth and fifth metacarpal on the hamate, because now they are convex. So radial glide would be to do abduction, because it would be an opening, so it would go this way. And this one, because it's convex, even though we're going that direction ulnarly, there would be a convexity, so it would do this. Again, can we really glide them? Perhaps we can do some of the conjunct rotation when we do our flexion and extension. And again, accessory glides of adduction relative to the third, ulnar glide of the second, because if we're adding the second here, glide will be in the same direction because it is concave. And then also with the fourth and fifth would be more of an ulnar glide, again, because if we're adding the fourth and fifth to the third, then there will be movement of an ulnar glide, because it would be a convex on concave movement. The MCP joint, so metacarpal phalange. So now we're moving up to the metacarpal phalange. We had been on the CMCs. Now we're going to move up here to the head of the metacarpals and the proximal, the base of the phalanges. So the middle phalanges, the MC3 and the capitate, are the axial bones of the hand. The orientation of the wrist ligaments tends to absorb stress and condense forces towards the large central capitate. So again, the second and third metacarpal are more stable, provide a strong base for thumb opposition, and the fourth and fifth are more mobile to allow adaptation to all surfaces with grasp. Direction of the interosseous ligaments, again, they're pointed up toward this middle articular pillar. So the MCP is the articular surfaces. The metacarpal heads, so the metacarpal heads, which would be here, or this part in my hand, they are convex, narrow dorsally, broader more palmarly, because they need more articular surface to close our hand, shallowly divided on the palmar surface to become bicondylar. The proximal phalanges, our bases are concave. So if you're mobilizing the phalange on the metacarpal heads, think of a concave surface. The radial and ulnar collateral ligaments taut in flexion and slack in extension. So at that level, these are the only ones that we're going to test our ligaments in flexion. So MCP flexion is how we're going to test our ligaments, where the other ones we're going to test with the DIPs and PIPs in extension. They're oblique in orientation, and they are posterior to the joint axis, attaches the dorsal MC head to the palmar proximal vase, so dorsal to palmar. The MCPs, like I said, are the only joints in the hand tested in flexion. These are the collateral ligaments. We have the palmar ligaments as well for the MCP joints. So palmar, they are thick, dense, and fibrocartilaginous pad, which are the volar plates. The volar plates are the palmar plate, and they are grooved for the flexor tendon. They are between the collateral ligaments, and they attach to collateral and deep transverse metacarpal ligaments. So they have these deep transverse metacarpal ligaments in between. They have a loose attachment to the metacarpal and strong attachment to the phalanges. So the ligaments have a stronger attachment to the phalanges than the metacarpal. The deep transverse is on the palmar surface. 3 short, wide bands connect the palmar ligaments of the MCPs to the 2nd and 5th metacarpal phalanges. They are taut in flexion to help form grip. The capsule, though, for the MCP is thin and loose. It's reinforced palmarily by the volar plate. Sagittal band maintains position of the extensor tendon, and it does not encompass the intermetacarpal joints. So it's different than what happened at the CMC, where the intercarpals and the CMCs were all in the same capsule, which is not the case in the MCPs. The intermetacarpals are independent. CMC joints, the classification is synovial, it's simple, and it's a modified ovoid. So the degrees of freedom are flexion, extension, and abduction. Closed pack position is full flexion, like we said. Resting position is slight flexion. Capsular pattern is loss of flexion more than extension, and you'll see that theme throughout the hand because functionally we want to be able to close our hand. So it's a capsular pattern if you've lost that. Normal infield will be capsular. Flexion extension, impure swing about a coronal axis in a sagittal plane. And again, because we've got that folding and fanning happening, we have that conjunct rotation as well. Don't forget the thumb is not involved, and the base in the middle is the pillar is the 3rd row. Abduction, impure swing about a sagittal axis. So supination goes with fanning, goes with abduction. We want to open our hand to take the money. And then the conjunct pronation or folding and adduction. Full flexion restricts abduction and adduction range of motion, of course. So accessory glides for the MCPs, it's female in all directions. So the base of the phalanges is female in all directions on the metacarpal. So flexion would be palmar glide, extension would be dorsal glide. Abduction, now again, adding, because ab and adduction we talk about to the 3rd. So because they're all concave on convex, if I want to add the first one, then, where this is abduction. If I want to ab away, so then I'm going to do a radial glide toward the radial side here. And then if I want to abduct this side, it's going to be an ulnar glide. And of course, for adduction, if I want to add the first one, the glide will go in the same direction, so it would be an ulnar glide. And if I want to add the 4th and 5th, it will be a radial glide. The IP joint. So now we're up here into the fingers. So classification is still synovial, simple, but it's a modified Seller because it's not ovoid in all its directions. It's not concave in all the directions. The degrees of freedom is just flexion and extension. The full closed pack position is extension, resting position, slight flexion. Capsular pattern is loss of flexion more than extension, and the normal end feel, again, is capsular. Flexion extension of the PIPs and DIPs. So impure swing about a coronal axis. Again, we're talking about that conjunct rotation, which we've already indicated. It stays the same as you go further down, even as you go into the joints of the DIPs and PIPs. So the accessory glides of flexion, palmar glide of the distal phalanx on the proximal phalanx, because in that direction it is concave, and dorsal glide for extension, but you can add your rotations depending on the direction you want to go. And here's the interphalangeal joints just to look at the ligaments. The articular surfaces, like I said, the base is concave in dorsal palmar direction, but it's convex, as we see here in the radio-ulnar direction. The head and the articular surface projects dorsally and palmarly. I think that was well said there, the head, there we go. And that's the end of the hand, or fin de main. Thank you.